Good evening, all the students present here. The topic for today is obstetric emergencies, but it is a CCS session. And the speaker that we have here is Associate Professor in Anesthesiology and Critical Care, AIMS Patna. Thank you, sir. So you may start.
Good evening, Neeraj.
Good evening. Good evening.
मैं
Where are you? You are
मैं फातिमा का सिस्टम से ऑन ये किया हूँ.
you are in dark background, I think. Okay.
Oh,
So we are
Fatima,
starting.
congratulations.
Thank you, sir.
Fatima has
Thank you very much,
completed
sir.
management degree.
अरे वाह, चलो. Heartiest congratulations, Fatima.
Thank you,
Very
sir. Thank
nice.
you, sir.
Very nice. चलो ठीक है. So, a very good evening to all of you and all the students, those who are ready to join today's class. I think today class is very, very interesting because what I see that many of you are new in this batch. So like I think Rajan and Pika and then I think Tom is there. So I think it is very interesting. It's a basically a STEM based class in which I will be giving you a STEM and then we will be discussing that how the questions in the real examination in EDIC will be going to get asked. Okay. So as this topic is related entirely to obstetrics critical care, so I will be touching few important aspects that my STEM will start with a case and then after that we'll touch different important aspects of obstetric critical care that like that we will try to judge you on the basis of whether you have any idea about severe preeclampsia, then later on after that the concept of amniotic fluid embolism, and then later on we will take you to therapeutic plasma exchange and then DP mass system, that what is the new technology that is DP mass and how it is better over hemoperfusion for, and because the last resort is definitely a liver transplant, but we will not going to that extent, but we will be closing our session till the difference between that your hemoperfusion as well as DP mass. So I think if you will have any doubt in between the class, you can definitely write on the chat box for any queries related to today's class. Okay. So now the thing is that your the case scenario is, so every case scenario has around, I have kept around 5 vignette. Okay. So the first case scenario starts with a 28-year-old G2P1 and patient that is admitted to labor because she was having a labor and delivery at 28 weeks of gestation. But now she has started complaining of headache as well as blood vision. Okay. Now her BP was 200 by 110 with 2 plus proteinuria on urine analysis, and repeat blood pressure a few hours later is 160 by 110. So the two reading of blood pressures was taken care of, and both the blood pressures were from 200 to range to 160. And meanwhile, the lab values has also come, and the lab value was showing a normal hematocrit and with a normal platelet count and normal liver enzymes level. The vital signs recorded at the time of admission was the blood pressure 180 by 110, heart rate was bit tachycardic 123 by beat per minute. The patient was tachypneic also 25 breaths per minute, and temperature was 34.2 degrees Celsius, and she was maintaining oxygen saturation at 98% on room air. Now, on quick physical examination, the patient, the examiner noticed that no pallor and icterus was there. Although what he noticed that the swelling of a head, hand as well as face was there, and CNS was in CNS system, the typical findings like blood vision, severe headache was there. And on routine examination urine, it was showing more than 300 milligram percent of protein in last 24 hours collection. So 24 hours collection shows this. So the first in the vignette 1, the first question was that because we have a set of 5 questions. So the first question was, how would you define preeclampsia and severe preeclampsia? So you have to you have to be very precise, because when we will discuss all those things in our mock class or in the real exam viva, the question will be like that, and then we will ask the student to answer without seeing anything, without seeing that mobile and all. So he or she has to on the screen, and then he has to answer this. So define preeclampsia and then what is severe preeclampsia, because today is our class, so we'll discuss all those things step by step. And then the simultaneously the next question was that, can you enumerate the 6 appropriate lab investigation that is required to assess the severity of the preeclampsia, whether that preeclampsia is moderate in type or severe in type. How can you label, or how can you know whether there are some important investigation that is attached which judges the severity of preeclampsia, and then how this patient has to be delivered, whether she can delivered expectant or some special care is required for this patient, and then what are the potential causes if the patient land up from preeclampsia to eclampsia. So what could be the probable cause of convulsion in third trimester of pregnancy or puerperium, and then what are the agents that you will not use in the management of severe hypertension, especially in preeclamptic patients. So these are five important sets of questions, and each questions has to be answered. Okay, so if in the real exam, if you have to answer, then you have to answer like that. There are two cardinal features which makes a diagnosis of preeclampsia, because first we have asked about the preeclampsia. So there should be a sustained hypertension. How will you know that the patient is having a sustained hypertension? If the systolic blood pressure is more than 140 and diastolic is more than 90, it is for preeclampsia. Okay, and then what is the status of proteinuria? I think Hassan, can you mute your mic, please? Hassan, please mute your mic. Thank you. So the second point is the proteinuria. What is the level of the protein that is present in 24 hours after urine collection? Whether it is more than 300 milligram protein is there or not. So for defining preeclampsia, these two definition has to be there. And then if the systolic blood pressure from 140 to goes to 160 and diastolic from 90 to goes to 110 on two different occasions, at least 2 hours apart, with proteinuria more than 5 gram. Now it is 5 gram in 24 hours, not less than 300 or not less than 300 milligram. It is up to 5,000 milligram in 24 hours. Oliguria, now the urine output is reducing a bit. It is less than 500 milligram in 24 hours, ml in 24 hours, and then elevated serum creatinine. The patient should show sign of pulmonary edema or cyanosis. The patient will have a persistent headache. The patient will have a visual disturbances, and the patient will have a seizures, some seizures features as well, because in many times the preeclampsia patient, they may present with some of the time convulsion, but not always they will present with convulsion, and the patient will have a typical epigastric or right upper quadrant pain with elevated liver function test. So these may be one of the findings in case of severe preeclampsia. So all those parameters will be normal, and then your lab parameters will be started to deteriorate, and the thrombocytopenia will be there. The patient will may be having a deranged PTINR as well, and the patient will have, at this point of time, the mother may be having a oligohydramnios as well as decreased fetal growth, or the patient present with placental abruptions. So these all are signs which is mimicking or which is making a diagnosis for a severe preeclampsia. So in real exam, you have to tell us 2 hours apart definition, cutoff value of blood pressure, and then these are the classical clinical features for defining a patient for severe preeclampsia. Okay, so this is vignette 1, question number 1. Now coming to the next part, that what are the laboratory investigation that is required for this patient for showing that, with how can you know that the patient is having a severity in the preeclampsia as well. So that is again, yes, many of the times it is mostly associated with the eclampsia are mostly associated with seizures, but few of the patients may present with, in severe stage or is in severe preeclampsia, the patient will may throw a seizure. That has to be there, although the percentage is very less, but it has to be there. Maybe there are cases that the seizures is there in severe preeclampsia, but not in mild, not in moderate. It is in severe preeclampsia. Okay, now coming to the appropriate investigation, that is why this is that is important, is what are the various laboratory investigations which I already discussed. So here the lab investigation will start with your CBC count first. And then you, apart from your CBC, then your blood urea nitrogen, serum creatinine, and then serum urate level. You may be in severe preeclampsia, the patient will, in severity, the patient will show a transaminases, so transaminitis will be there. The deranged in coagulation profile, the patient may be having a thrombocytopenia features. Here many of the time the student forgot to tell this. So this is important one, because in every exam they doesn't able to talk about that blood typing and antibody screening, because at this point of time this is important, because the patient the patient blood grouping and blood timing or antibody screening is always required. And then your 24 hours urine collection of the protein, which you already seen in previous slides, that how the protein from 300 goes to 5,000 milligrams in 24 hours collection. So these are the 4 or 5 sets that you have to think of for labeling the severity. Now coming to the third question, that what are the potential causes of convulsion in third trimester of pregnancy? Now again, there may be the patient will present with seizure. So what will be the causes? So if the patient is throwing with a seizure, especially in third trimester of pregnancy or early puerperium, then you should consider at least these three important parts, like hypoglycemia, like ICH, so intracerebral hematoma or intracerebral hemorrhage or cerebral venous sinus thrombosis, and then your epilepsy. If the patient is already having some history of epilepsy, means history previous, or cerebral venous sinus thrombosis, or the patient has developed some recent ICH, or the patient is having a persistent hypoglycemia due to some any forms of infection or something, like the patient is having some insulin resistance types of thing. So these could be one of the probable features of eclampsia, probable features of eclampsia until proven otherwise. Because to prove eclampsia, the preeclamptic features has to be ruled out. Okay, so this is how we finishes the third. Now, the last one, that what are the agents that you should avoid? We all know that what are the agents that we should use for treating the hypertension in the preeclamptic patient. But here the question is what agents that has to be avoided here. So for avoiding, you have to take care in your mind that yes, the first everything has to remember with a proper justification, that ACE inhibitors and angiotensin receptor blockers like ARBs both are contraindicated for the acute management of preeclampsia if it is secondary to neonatal renal failure. So if the baby is having some signs of neonatal renal failure, so definitely these two drugs are contraindicated. And because they have a very delayed onset of action, it takes around 4 hours, at least minimum of 1 hour and maximum of 4 hours for their onset. So it is always delay. And then the second point is always be aware of the use of nifedipine. Why? Because in many of these patients, the magnesium sulfate is being used. So it has a very poor conjunction, because always the problem is there that it always exaggerate the hypotensive episodes in these groups of patients, and very rapidly the hypotension appears if you are trying to manage this patient who is having a preeclamptic features or having a severe hypertension. So that has to be taken care of, and it must be given very cautiously. If the patient is on magnesium sulfate, so much caution is required. And then drug commonly used in acute settings. So what could be the drug? So we all know that hydralazine, then followed by labetalol, nicardipine, and nifedipine. All those drugs can be used in the acute settings. So this is how we covered the first vignette, which consists of 5 questions and then its explanation. Now the second vignette is the similar case after 1 week of preeclampsia. She has started of complaining abdominal pain and nausea, but the blood pressure is now normalized, and the blood pressure was 135/87. Initially, the blood pressure was 200, then it was 160, and now it is normalized. The 1 week already passed in the preeclamptic phase, but now the peripheral blood smear has started showing some helmet cells. You can very well appreciate how these helmet cells look like. So you see that these are just type of helmets. So these are the helmet cells. Here you can also see that helmet cell, which is also known as cystocytes. So these cystocytes are present in the peripheral blood smear, and there are also some presence of some Burr cells also. So the Burr cells was there, and then cystocytes or helmet cells was there. And on quick laboratory investigation, the patient was showing elevated AST as well as ALT value, and it was more than 80. And then the patient was also showing reduced serum haptoglobulin level with serum bilirubin, elevated serum bilirubin level, and now the platelet count was started to drop. So platelet count initially was normal, but now it is less than 88,000. Now, at this point of time, I framed 5 different questions: that what is the diagnostic criteria for HELP syndrome, because the patient is going in HELP because hemolysis is there, then elevated liver enzymes are there, and then low platelet is there. So I want to ask here at this point of time that what are the 2 classification that is very common commonly associated with HELLP syndrome first. And then my second question is, can you tell us 5 different differential diagnoses for HELLP syndrome? And then what are the complications that will be following HELLP syndrome? And then how will you manage this HELLP syndrome patient? And then are there any role of systemic steroids in the management of HELLP syndrome? And then if you want to do a cesarean section, can we do that? Can we have a advantage of doing cesarean section, especially in HELLP syndrome? So these are few 5 sets of questions. So just see the answer one by one. So the first diagnostic criteria, I know all of you must be knowing this Mississippi classification, where the class 1 suggests more severe and class 3 suggests less severe HELP. So class 1, the platelet is less than 50, means less than 50,000, and for class 3, the platelet will be more than 1 lakh to 1.5 lakhs. But here the AST, ALT value, AST, ALT as well as LDH value will be equal in all 3 groups. Either it will be class 1, class 2 or class 3. So it will be more than 600 and it will be more than 40 and it will be more than 70. Here only the problem is that here the in your class 3, the AST, ALT will be more than 40. Otherwise, in both the groups, the AST, ALT will be more than 70 and LDH will be more than 600. But here the student doesn't able to tell Tennis classification. So you have to know that there is another classification, that is Tennis classification for HELP syndrome, for classification, for knowing the severity. So it has 2 parts. One is true or complete and second is partial and incomplete. So the true or complete is almost equal what the Mississippi classification is all about, but only the cutoff of platelet is less than 1 lakh here, and AST more than 70 and LDH more than 600. So rest 2 findings are almost same, that it is matching with your class 2, but the platelet count will be less than 1 lakh. But here in partial or complete, the patient will have a severe preeclampsia, always severe preeclampsia with any of the following. Either the patient will showing your absence of hemolysis with low platelet and then elevated liver functions, or the patient will show low platelets or elevated liver functions, mean separate of all those things. Not all, not HELP, but either HELP, either HEL, or either EL or LP. So it could be. So the classification has to be there. If you spoke Tennis, then at least you should know that, sir, these are 2 class, like one is true, one is partial, and these are the few examples of true and false, true and incomplete classification. Now here at this point of time, what is the differential diagnosis of HELP syndrome that is coming in your mind? So what DDs that you will keep in your mind for diagnosing if you have diagnosed HELP syndrome? So you have to think at this point of time AFLP and then acute viral hepatitis. So you have to do all those viral markers, whether the patient is having a hepatitis A, B, or C, or E, and then whether the patient is showing some symptoms of AITP, that is autoimmune thrombocytopenic purpura, or TTP, whether is there, or HUS there. So whether HUS TTP complex is there or not, or whether autoimmune thrombocytopenic purpura is there or not, or acute viral hepatitis is there or not, or AFLP is there or not. So these all are your DD of your HELP. So that has to be kept in your mind. Okay. In the exam, many of the times, what is student able to tell? They able to tell this, they able to tell this, and then they used to forget these all 3. So these 2 are very frequent because they are already coming in various minds, but these HUS TTP complex and there your ITP has to be remembered. Okay, autoimmune. Now coming to the complication, I think it's easy. Complication is very easy because DIC definitely everyone can tell, ARF everyone can tell, and then pulmonary edema or pleural effusion will be there. The patient may be present with some hepatic capsular hemorrhage or hepatic infraction, or the patient will have a ARDS or placental abruption. All these findings, because this is associated with severe preeclampsia. Severe preeclampsia with HELP can lead to all of these findings, because the patient will have in the background severe preeclampsia and then HELP is developing. So it is coexisting with this. So I think placental abruption and ARDS can be there, and then hepatic rupture. Hepatic rupture is again very classical features present in severe preeclampsia. So it has to be remembered. And then it is one of the complication in HELP also. Now, how will you manage HELP syndrome at this point of time? So for management of HELP syndrome, what do you want to do? First, priority is delivery of the fetus, and placenta is the main. So you want to deliver not on the fetus, but you have to deliver the placenta as well. And then timing of the delivery is dependent on the severity of the symptoms. So that has to be maternal stability, fetal stability, and gestational age. So all these things has to be kept in our mind. Then you can target the delivery. And then treatment should be always supportive. At any point of time, the patient may need a SDO or ICU sets of admission. So you have to take care of that. And without having a booking of the seats in the SDO or ICU, it is difficult to provide a supportive treatment in the ward, basically in the labor room and all. So it has to be taken care of. And then you have to delay the delivery for a period if you see that the patient mother fetus is immature. So if mother fetus is not mature, so you can delay the delivery. And meanwhile, at this point of time, what you can do, you can administer a steroid to reduce the risk of your neonatal respiratory distress syndrome, because it will it will improve the fetal lung, or it will mature the fetal lung, or it will decrease the incidence of neonatal respiratory distress syndrome as well. Now, what is the role of, now again question is, what is the role of systemic steroids in HELLP syndrome? Now you see the use, if you'll see a Cochrane database from which is published in 2010, they suggested that if you want to use systemic corticosteroid in HELLP syndrome, HELLP syndrome, it may increase the maternal platelet. It slightly increase the, not very much increase, but it slightly increase the maternal platelet count, but it has not shown a mortality benefit or infant mortality. It has no effect on the infant mortality, maternal mortality, or progression of the disease. So you can't improve the progression of the HELLP syndrome if it is going, and if you want to give a steroid at this point of time. Only the one point is, if the patient is having a less amount of platelet, not very less, where the indication of platelet is there and you want to give a steroid, it will not work. So it is only partially, it will increase the platelet count, but other things that you have to must be kept in your mind. I think, Arsa, please mute yourself. Thank you. So I think these two important aspects has to be taken care of. And meanwhile, after going all those questions, now the next question is that what could be the other things that you want to do in, especially in a HELLP syndrome patients. So the patient has to be continuously monitored with your cardiac topography. So CTG monitoring is to be there. And then if you want to deliver the fetus, only once the mother is stable, because I have already talked about the three different aspects: your mother stability, your fetal stability, and then you have to look for whether the patient is your backup of ICU or SDU is there or not. And then vaginal delivery is not contraindicated if the cervix is favorable. If you are getting a dilatation in proper time, if the cervical dilatation is achieved, you can attempt a vaginal delivery. It is not like that it is contraindicated and all. But if HELLP syndrome is coexisting, you can consider high dose of steroid in these patients, and then always try to involve a multidisciplinary teams like liver gastrophysicians as well as nephrologists. And then third stage of labor, how are you going to manage this third stage of labor? Why? By using your oxytocin rather than symptometrine and ergometrine, because what will happen at this point of time, because if you are managing the patient with preeclampsia, with having coexisting HELLP syndrome, and then you try to deliver this patient, the blood pressure, indirectly the blood pressure will also rise, and then the vicious cycle will continue on. So it is better that the oxytocin is always better over symptometrine or ergometrine. Okay, so these are few of the points that you have to keep in your mind while attempting the viva questions. Now, what could be the indication of cesarean? Now, again, it's a very straight question, but in the exam, many of the time, the student doesn't able to tell us. They're stuck in two or three options, like sir, the patient will have a abnormal fetal presentation, or the patient will have the fetal status of that patient, it depends on the fetal status. No, but you have to tell us that what are the specific indications of cesarean sections while the patient is having a HELLP. So non-reassuring fetal status first, and then if you are getting abnormal fetal presentation, if the mother is less than 30 weeks of gestation with a BISAP score of less than 5, so you must go and leave that BISAP score. So what are the various components of BISAP, and what are the cutoff of BISAP for which you have to do a cesarean section? And then if the patient is having a less than 32 weeks, now the cutoff is less than 30 with a BISAP less than 5, but if the age is less than 32 but the patient is showing IUGR, then you have to take this patient for cesarean delivery. And or if the patient is having oligohydramnios or a BISAP score of less than 5. So or if the patient is having showing some subcapsular level hematoma as well. And then last, your abruptio placentae. So these are all are the findings of going for cesarean sections associated with HELLP syndrome. Now we are coming to the Vignette 3. Now the similar patient, Now we have taken this patient for OR in view what was the abnormal presentation of the fetus. The patient was showing a features of health. Now the patient was decided that the patient needs a cesarean, so she has been taken inside the operating room, and the indication was abnormal presentation of the fetus. Now what has happened? Eventually, the patient was started hypoxemic, and the SpO2 was falling from 90. It was maintained, but it went to 82%, and the patient was complaining of sweating. Then lots of shivering was there. The patient was having a dyspnea, some cyanosis, peripheral cyanosis, and has developed in this patient, and the patient was bronchospasm on auscultation. When the cesarean was started, and the vitals at this time was heart rate was maintained, but the patient was having a very fall in blood pressure, 90/40, and the patient was very tachypneic. Even the temperature was 33.2. It was not very high, but the respiratory rate was very high. So at this point of time, again, I made 5 different questions that you all guys can think that what could be the probable questions that will come in this vignette. So the first question was what are the risk factors for now this patient has started developing amniotic fluid embolism. So what would be the different factors that you will look for? So 5 different factors responsible for AFE, and then a few steps of pathophysiology. Examiner may want to test whether you have understanding of knowing that why hypoxia has been developed in acute for amniotic fluid embolism. So pathophysiology, maybe they will ask. I think many of the students have answered very well in the previous viva that what we have conducted. And then other thing is that what could be the other diagnosis, what could be the other DD if a pregnant patient presented with profound cardiorespiratory compromise, like fall in blood pressure, tachypnea, hypoxia, like that. So, and then what are the, so I think this is the right time to ask about the DIC score, whether you have any idea about DIC score and what is the minimum cutoff to level this patient is for being a patient to be a positive DIC score. And now this is one of the, now this is again a difficult question that I have added. Only why? Because we all can go and read that what are the various biomarkers that for amniotic fluid embolism, at least name 3. So these are the at least 3 biomarkers, but I will discuss the lots of biomarkers here. But at least you have to remember that what are the serum biomarkers for making early diagnosis or aiding in diagnosis for amniotic fluid embolism, and then how will you manage this patient. So it has started with risk factors and it ends with the management. So the first answer would be, so there would be many risk factors in this patient. Particularly here, I think the patient was having a fetal distress. So one of the risk factors, the patient may be having an induction. If you have started induction of labor, if the patient is having a forceful uterine contraction, the patient is advanced maternal age, if more than 50 or 55 years of age, if you are trying instrumental delivery, if the patient is multipara, again the problem will be there. If the patient is having a placenta previa or underlying abruptio placenta is already there, the patient again will be having a risk for AFE. And the patient, if the patient is having some cervical lacerations, again this will be one of the problem. And then fetal distress I already discussed, and then eclampsia. So these eclamptic patients again have a more risk for development of amniotic fluid embolism as well. So these are the one of the questions for amniotic fluid embolism. And now the second part is what is the potential pathophysiology. So the pathophysiology is very common. You will be getting a VQ mismatch in this patient. One of the significant or you can say that profound problem or dominant aspect, that VQ mismatch will be first, and then followed by pulmonary vasospasm. Then the patient will have a pulmonary edema. Why? Because these patients will have a compromised heart. That's why the patient will have acute left ventricular failure or acute left ventricular dysfunction leading to pulmonary edema as a result. And then patient will have a bronchospasm. So, but I think these 3 suffice if you'll are able to answer that either combination of VQ mismatch, patient will have a pulmonary vasospasm, or the patient will have a acute left ventricular dysfunctions leading to pulmonary edema. So these could be one of the probable causes for explaining the hypoxia in your amniotic fluid embolism patient. Now, what will be the other diagnosis? Now, again, this is an important question, that what could be the DD at this point of time that you will think of. Their examiner may want to test that whether you are aware about other DDs or not, or whether you are only thinking about amniotic fluid embolism. So at this point of time, I will definitely think of everyone used to tell this for pulmonary embolism and air embolism, but they used to forget anaphylaxis. Doesn't used to forget pulmonary aspiration. They used to tell, but they used to tell forget septic shock and myocardial infarction. So at this point of time, if the patient will have acute ventricular failure with setting of some STMI or non-STMI or cardiogenic shock, all can lead to your patient will have cardiovascular compromise as well. So first pulmonary embolism, air embolism, then anaphylaxis, aspiration, septic shock, and your acute myocardial infarction. So this could be one of the findings. Now, the next point is that what are the parameters in the DIC score and what is the minimum score? So the DIC score, as per your ISTH classification, the DIC score cutoff point is more than equal to 5 for a positive for DIC. And if it is less than equal to 5, the patient will have a negative DIC. But definitely, these patients may be having a non-overt DIC. It can be also labeled as a non-overt DIC if you'll get a score of less than 5. And it could be, if you are not going to manage that patient from non-overt DIC, it will convert into a frank DIC. And that's why the concern is that the patient is having an ongoing DIC. So what are the points? So for DIC, you need to text your INR directly, or either INR, or you can have a PT or fibrinogen level, D dimer, as well as platelets. Okay. So for 0 point, if it is everything is fine, so platelet is more than 1 lakh, D dimer could not be there. It should be normal. Fibrinogen level should be more than 100 milligram per DL. And then your prothrombin is almost normal, less than 3 seconds. And then your INR should be normal, less than equal to 1.3. So if your INR has started to deteriorate from 1.3 to 1.7 or more than 1.7, your points will be increasing like that only. And if you are getting more than 10 times upper limit normal, the D dimer, so it will fetch 2 points. So this is more than equal to 5 points positive for DIC, and less than equal to 5, it is negative. But definitely you have to think of non-over DIC. Now, at this point of time, for acute DIC, what will be the problem? The patient will have a decreased platelet count. The patient will have a absorption of fibrinogen. So fibrinogen will be falling. The patient will have a deranged INR, and the patient will have a more APTT values, and the patient will have a very increased D dimer. And this, meanwhile, if you want to see, you will see more and more helmet cells or cystocytes. So here, these two will be there on peripheral smear. So if they will ask that, tell us the acute DIC lab findings. So you have to explain like that platelet count, fibrinogen, PTINR, APTT, then PD dimer, as well as your peripheral smear. So now coming to the next part that what is this all about? Okay, let again the same thing that what I have already discussed about this is what is overt DIC and what is early phase DIC. So it is again in basically this is SIC, sepsis induced coagulopathy. In sepsis induced coagulopathy, another parameter like SOFA used to come in the scoring system, but definitely with time you can see in the Y axis the coagulopathy is there, and then in X axis the time is there. So the more is the time, the patient will land up in overt DIC later on. So if from early phase DIC, the patient will land up in overt DIC, and if the cutoff is more than equal to 5, you can diagnose the patient is having a DIC. So this is for you all, because sepsis is an insult and it will affect the platelet count as well as PTINR. Now, this question, what are the various biomarkers? So definitely you have to remember few of the biomarkers like activin A, and it increases with in gestational age, then your BNP, then your CA125, then your C1 esterase inhibitor, then your CEA, carcinoembryonic antigen, and then your chromogranin A, then your endothelin, and then few of the time fetal cell cytification using MAT circulation. I don't think so that it is important to remember, but insulin-like growth binding protein 1, that has to be remembered. And again, your interleukin 6, interleukin 8, and then pro-collagen type 1 N-terminal glycopeptide. Again, these are important. Why? Because if the patient is developing SIRS and the patient is having a AFE features, you can diagnose these based on these IL-6 and your tumor necrosis factors. Okay, so these are few, but you can see that how specific it is in diagnosing for amniotic fluid. Okay, so this is few of the biomarkers that you have to remember. Now coming to the next part. So how are you going to manage? So management is very simple. You have to take care of airway, and then you have to provide 100% oxygen, positive pressure ventilation, and then large volume of blood, fresh frozen plasma, platelet, fibrinogen, because all these are going down. So you have to manage, and then you have, at this point of time, you can definitely use your Rotem or TEG for managing this DIC, because it will give a very good picture, because you must be aware about the TEG findings, that they have two components. Like the first phase till your maximum amplitude, it will be showing you the types of that coagulation defects that is going on, and after maximum amplitude you can able to know about the fibrolysis. So I think that finding is very, very important, and in TEG all those findings like K, like alpha, like your alpha angle, as well as maximum amplitude, and then your lysis at 30%, you have to remember all those things key for managing early or late DIC. Okay, and then after stabilization you can transfer this patient to the ICU. So this is how we finishes again another vignette. In this another vignette, we have tested the knowledge about amniotic fluid embolism, and then from severe eclampsia, patient landed into acute your FA, amniotic fluid embolism. Now this is the vignette 4. Here now what has happened, this patient has developed acute amniotic fluid embolism. So patient was immediately shifted to the obstetric ICU on third day ICU admission. The blood pressure got stabilized, another vital were also trying to improve, because we have intervened that patient for proper management. And then now the problem is the patient now started developing epigastric pain. So now epigastric pain was associated with few episodes of vomiting as well as hypoglycemia, especially on the fifth day after the ICU admission. The patient was having a pallor, the patient was having icterus, the patient was having a cerebral edema or pedal edema, and the patient was having a signs of altered sensorium at this point of time. So again, now I have thought of that what questions that will come in our mind after gaming this scenario. The patient is having a hypoglycemic, vomiting, epigastric pain. After 3 days, 5 days admission inside the ICU, the patient was having icterus, and then CNS problem was there. So at this point of time, I was talking about AFLP. So now this patient has started to develop what are the serious conditions that we are dealing here in the postpartum period, because now the patient is in postpartum period. So what will be the serious condition, and then what could be the pathophysiology, and what could be the important features. Now at this point of time, I think for amniotic fluid embolism there is no such proven pathophysiology, but definitely you have to talk about your fatty acid oxidation defect. And now you have to talk about important some highlighting mechanism that we will discuss right now. And then we will also discuss what are the 5 diagnostic feature, what is Swenson criteria, and what Swenson criteria is all about, and then what how will you differentiate at this point of time from HELP to AFLP. So AFLP say HELP ka differentiation, how will you going to do that, and then what are the various steps of management for AFLP, and what could be the first sign, how will you know that the patient has started showing the signs of hepatic recovery. So these are a few questions. So these again 5 sets of questions. We'll start with the serious condition, that what is the serious condition that we are dealing about. The serious condition is the AFLP. Okay, now coming to the next part is what could be the pathophysiology. I think the serious condition is AFLP, but here I think I have given more emphasis for this pathophysiology. So what happens exactly, you try to understand. So there are 3 places. First, your placenta. Second, is your circulation, like in the blood level, and third is your liver. So at three different time points, the problem will be there. So what will happen at the level of placenta? The patient will have a defective placental acid oxidation defect. So fatty acid oxidation will be a problematic one. So what patient will try to do? The patient will have a pregnancy-induced lipolysis. So lipolysis will do what? It will generate more and more free fatty acids. So what this fatty acid is all about? This fatty acid is ultimately responsible for formation of style CoA. And how these style CoA is going to get formed? By the formation of 3-hydroxyl acyl CoA. Okay, and how these 3-hydroxyl acyl CoA is going to form style CoA? By the formation of 3-ketoacyl CoA. So here I think the important point is the free fatty acid and 3-hydroxyl CoA or acyl CoA. These are the 2 factors that is responsible for providing oxidative stress, that is going to do mitochondrial dysfunctions, more and more lipid accumulation, and then lipotoxicity. So all these problem will be there if you have a defective fatty acid oxidation. So if fatty acid oxidation problem will be there, so more and more free fatty acids and more rapid conversion to 3-hydroxyl acyl CoA is there. But the problem is the defective enzyme is LCHAD. LCHAD. What is this LCHAD? It's 3-hydroxyacyl CoA dehydrogenase. So this enzyme is going to get defected. That's why acyl CoA is not going to get formed. Acetyl CoA is not going to form, and the patient will have a more level of 3-hydroxyacyl CoA as well as free fatty acids. In what level? In the level and the circulation in the liver and in the placental as well as in the placenta also. So all these will lead to your problem in the circulation. So the antioxidant effect of or property will go down, and the patient will have a more oxidative stress, but because the antioxidant will be not functioning there, and the patient in the liver, the patient will show a mitochondrial dysfunction, some apoptosis, and then microvascular steatosis. At this point of time, they may used to ask whether macrovascular steatosis will be there or not in the AFLP, but the answer is no. If you do a histopathology examination, the microvascular steatosis will be more over macrovascular, and very few macrovascular predominance are there, but mostly microvascular steatosis will be there because of the free 3-hydroxy fatty acids accumulation. So this is a nutshell about your fatty acid oxidation defect, that how these AFLP is going to develop inside the liver, or how the liver function is going to get deranged. That's why the problem is always lies with the liver. And then after that, if it is uncontrolled, then all problem will be there. Different organ functions will be affected. Okay. Now coming to the Swenson criteria, I think you must be knowing at this point of time, but I want to explain that what are the questions that they will ask in the Swenson criteria. I think 3 important parameters that you have to remember. That first is hypoglycemia. What is the cutoff of the blood sugar? That is 72. What is the cutoff of the ammonia value? Again, they ask, it is around 65 microgram per dl. And then third point, that what they used to ask is microvascular steatosis on the liver biopsy. So these are the important points. Apart from that, leukocytosis, encephalopathy, the patient, many of the time the patient will present with polydipsia or polyuria. This is very this is not very common, but few of the times the patient will start present with polydipsia as well, and the patient will have you can see that the patient will have a very elevated bilirubin. So this is the only problem. That's why the mortality is very high if the patient will showing that positive Swenson criteria, and the delivery is the only point for protection of this patient. Otherwise, you have to go for the liver transplantation. Now, 6 or more criteria. So 6 or more criteria is required for the diagnosis of AFLP in the absence of another cause. So at least 6 has to be there. So I discussed polydipsia, encephalopathy, bilirubin, hypoglycemia, leukocytosis, liver biopsy, steatosis, prothrombin time, and your renal impairment as well. Now, at this point of time, how will you differentiate AFLP from a HELP? I think you will able to answer that in HELP syndrome, the patient will have a transaminitis. AFLP, the patient will have a transaminitis. I have added another thing also, TTP-HUS, but you don't look for this part right now. It's better that you focus on AFLP and HELP. That transaminitis will be always more in FLP than in HELP syndrome. Hemolytic anemia will be always more in HELP, because HELP is for hemolytic anemia, but in FLP it is not like that. Thrombocytopenia will be always more in HELP syndrome. Antithrombin deficiency, here the antithrombin deficiency will be more in AFLP than in comparison with HELP syndrome. The DIC is very common. So these AFLP, we can have of understanding that the DIC is one of the complication for HELP syndrome, but in FLP the DIC is very frequent. So this is one of the important distinguishing features from AFLP to HELP, because the variable form of DIC you will able to see in the HELP syndrome, maybe very high, maybe very low, or maybe early, maybe late or over type of thing you will be seeing, and it is one of the complication. Hypoglycemia, again the second point that you will able to differentiate this AFLP from HELP is your hypoglycemia, and you can see that the renal sufficiency is almost common in both the groups. So based on the renal insufficiency, I think based on the renal insufficiency, if you like to help in the AFLP, the renal efficiency may be, the renal insufficiency may go up to 100%, but it is only 15% involvement. So the more and more renal problem will be there only because of that fatty acid oxidation defect and more oxidative stress and more and more that mitochondrial apoptosis. So all those findings can lead to your AFLP as well. So these three important findings, that more renal insufficiency, hypoglycemia common, and then your anti and thrombin deficiency and DIC. And then at last, the decreased level of antithrombin 3 are a common finding in FL. That's why I have written it in a different way for you all understanding. So till now we have discussed all those points. So last point is how will you manage this AFLP? So manage is you have to provide a maternal stabilization. What would be your focus? Your focus is to save delivery of the fetus in the patient with AFLP. First point. Longer the delivery, this is again a very important statement, that longer the pregnancy lasts, the diagnosis, the greater risk of developing the fulminant hepatic failure. So what happens, these groups of patient AFLP will land up in FHF. So FHF, if your pregnancy, if you are delaying that pregnancy for delivery, so the problem will be more, or always expected management is not an option. So you have to stabilize your patient for doing that delivery. Although delivery is required as soon as the mother's condition is stable, and there are no reports of AFLP resolving prior to delivery. So till now, there is no reports in which AFLP has resolved if you have not done a delivery. So delivery is a mandatory that has to be done as early as possible on maternal stabilization. So the second part, because the patient will have a frequent episode of hypoglycemia, so all those complications need to be managed, like hypoglycemia, like renal failure in case, because a very high bilirubin will be there. So strict monitoring in the critical care unit is required. Many of the time, the patient may be associated with acute pancreatitis, and 10 to 15% of the patient will present with diabetes insipidus. That's why the patient will have a polyuria and polyuria. And then plasmapheresis may be considered in cases where liver failure continues to worsen. You have done a delivery, but still the liver is not coming up, or still the liver is not improving. So you have to think of plasmapheresis. And then at the last, you have to think of OLTX, that is orthotopic liver transplantation if required in extreme of the patients. Okay. Now, I again ask one question: what are the signs of recovery, hepatic recovery in FLP? So the first sign is, if your prothrombin is started to improve, first sign, then it is indirectly showing that your liver is started to recover. And then other signs like normalization of your liver enzymes, like a decreased level of ammonia, then your coagulation will be normalizing. The patient will take some time for normalization of that serum creatinine as well. And then the liver function typically takes around 10 days. Even it takes more than a month for liver functions to totally come back in a normal place after delivery of the baby, especially in FLP. In few of the patient, we have witnessed the improvement, but in few of the patients, we have seen a deterioration like anything. The patient will improve, then patient will deteriorate, and then patient will improve, and the patient will deteriorate. In spite of doing all those therapeutic plasma exchanges, time to time, exchanges, again it has not worked at all. So even after we have done a delivery in those patients, so it looks nice when you get a AFLP patients for management inside the ICU, but any of the time the patient will slip from your hand. This is the only problem with AFLP, that it has got a very high mortality. Now coming to the again next vignette. Now here what has happened to this patient? Now here the patient now started a yellowish discoloration of the eye, and then urine, and then recurrent non-bilious vomiting on 7 days after admission. On 5th day, the patient was having a AFLP, but on 7 days, again, more yellowish discoloration was there. The patient was afebrile, but now she is drowsy. Initially, she was having an altered sensorium. Now she has a icterus, and then flapping tremor has started. The blood pressure is normal. The pulse rate is almost 100. SpO2 is normal. Respiratory rate is normal. Now, abdominal examination not showing any findings like hepatocytomegaly or no dilated vein over the abdominal wall is there. The patient is having a leukocytosis acidosis, thrombocytopenia, hyperbilirubinemia, transaminitis, coagulopathy. ABG is almost normal and urine depistic protein is negative. So at this point of time, again, I want to test your knowledge related to that the patient is now landing up in some other problem. The patient from AFLP, now it is slipping from our hand. So what could be the probable questions? So what is the diagnosis in this case first? And what are the etiological agent that is responsible for leading to this condition other than AFLP? Okay, because we have managed the AFLP initially, but now the problem is worsening. And then whether she has a persistent organ dysfunctions despite emergency delivery. We have taken this patient for emergency CS, but still the organ dysfunction is there. So what could be the problem? And now here, what is the role of TP in the management of above case? So I have added a TP aspects also for management. Now, for at this point of time, the first question, continuing to that, how does this TP work? Because now your patient is going in fulminant or acute liver hepatic failure. So what could be the TP? I want to knowledge the concept for TP. What are the adverse event of therapeutic plasma exchange? What are the main limitation of therapeutic plasma exchange? And what is the role of double plasma membrane absorption system like DP mass over TTP? If your TP is combined with DP mass, whether the prognosis is improved or not. So today we will discuss few things related to your TP as well as DP mass. So just see one by one. So here the patient is having a jaundice in late pregnancy. So your approach, first I will try to exclude all those pre-existing chronic liver disease, whether is there or not. I want to exclude portal hypertension as well. And then I will try to rule out some malaria or any form of your ventricular hemorrhages. Oh, sorry, acute viral hepatitis. AVH is basically acute viral hepatitis. I want to rule out. Then these are the few of the common causes of jaundice in the late pregnancy in the pregnant patients in the normal population. Then what I will do, if the patient is showing signs of acute liver failure, I will see whether the patient is having a thrombocytopenia, LDH value is elevated or not, or the patient is showing some signs of preeclampsia, plus or minus. Then I will make a diagnosis for help. If it is associated with preeclampsia, you have to think for help. And if it is showing coagulopathy, encephalopathy, hypoglycemia, I will be thinking of AFLP. So at this point of time, AFLP and help is very, very clear. But if AFLP, urgent delivery, hypoglycemia prevention, antibiotics. If help, urgent delivery, hypoglycemia prevention and antibiotics. So both the management is almost same. Now coming to the next part. So now this is this is NBAL. What is NBAL? Non-biological artificial liver. So I thought that I should add these 3 different slides for you all so that you can understand the concept of NBAL. What is this all about? So for non-biological artificial liver, what is there? In various ex vivo mechanical, it is basically a physiochemical biological device. What it does, it removes the toxic substances and it supplies the essential substances to the blood, and then it improves the internal environment, and then it replaces the functions of the failing liver temporarily. So definitely, basically it acts as a liver dialysis, or it can bypass your liver, and it can provide all those important substances that is essential for the liver. And these NBAL, like non-biological artificial liver, it is alleviate the liver burden on the liver, and it is restores the liver function, and it buy the time for liver transplantation. Basically, you can, in other words, you can say it's a bridge therapy for prior to going for an orthotopic liver transplantation. Okay, so few more words about NBAL. So today, till date, NBAL has been widely applied in clinical practice, first point, and its effectiveness is basically more studies. In some of the studies are there in the China, where plasma exchange is one of the most common technique for as an NBAL. That is your non-biological artificial liver. Sorry. So now second point, basically it has a plasma separator to filter the plasma from the full blood, and then it removes the toxic substance, and then it will add some of the essential elements, and then it will dissolve the plasma protein as well. And then what you can do simultaneously with while going TPE, you can add fresh frozen plasma to replace the coagulation factors and albumin. So FFP many of the times is being simultaneously given when you are planning for your therapeutic plasma exchange. Okay. Now, the in DP mass system, what it does, it has a not a single layer, it has a double plasma molecule absorption system. So it uses a plasma filter to continuously separate the plasma. Okay. And now what it will do, the plasma which is filtered, it will be passing through a specific bilirubin absorber, where all those plasma and the macroporous, they have a resin hemoperfusion. So basically it's a device, and this device, what it does, it specifically removes the all those toxic metabolites, basically large or soluble bilirubins, because here the bilirubin is going to high in these groups of patient. And then inflammatory mediators, various inflammatory mediators, they are going to absorb all those bilirubins as well as inflammatory mediators. And then what happens, all the after absorption, the remaining plasma again transfuse back to the body without any substitution of fluid. So this is only difference from a therapeutic plasma exchange from DP mass. In the DP mass, the substitution fluid is not given back, just like your fresh frozen plasma is additional, which is given along with therapeutic plasma exchange. In DP mass, it is not being given. Only it has a very high bilirubin absorbing system, which absorbs the larger molecule of bilirubin as well as metabolites. And the important thing, it may help in regeneration of the hepatocytes as well. So you must have to read these questions later on, because they may be going to ask in the exam. And now the indications, PEX is, it's a taking away, because it's a basically it removes a very large molecular weight, more than 15,000 daltons, like autoantibodies, like your immune complex, cryoglobulins, and then cholesterol containing lipoproteins as well. Okay. Now coming to the this is what we have discussed about that therapeutic plasma exchange, that what how it will be there. So basically in what one point of time, the blood is pumped out. So through a blood pump, the blood is been uh, pulled out from the body, and then anticoagulant has been added, and then it is been passed through one of the filter. Okay, so this is your plasma osmotic based on the osmotic pressure. And here again there is a substitution fluid that is going on, and here the waste is again rolled out through a plasma pump. And here the substitution fluid, that is your FFP, is been given through a roller pump, and then through a plasma separator, again it goes back to the body. So this is how the toxic metabolite has been removed, and along with substitution fluid it has been given. This is not going to get happen in DP mass system. Okay. Now the what are the problems that you will face when you will start therapeutic plasma? Allergic reaction, paresthesia, hypotension, chest pain. The patient will have a clotting problem. The patient will have a hematoma at the puncture site. Pneumothorax fall can lead to these are the few of the complications that you have to tell to the examiner, from paresthesia to infection at the catheter site. Okay. Now coming to the proposed mechanism, because one of the question was there, that TTP, how these going to help. So these TTP is helping the hepatic recovery, including why? Because the toxic substance will remove, and you want to supplement the coagulation factors and albumin. First point. One of the study which was published in 2012, they showed that if you will want to do TP, what does it do? What does it to the body? It induces superoxide dismutase formation. So the malondihyde production will be going to get inhibited. So caspase 3 upregulation will be inhibited. So oxidative stress or oxidative damage that is happening inside the liver, that will be halted. Why? Because of the upregulation of the caspase 3 and caspase 9. So these are the two pathophysiology or pathogenesis why it is responsible. So in one of the study, they have proven that advantage of TP. But what I have taught you, that for DP mass also, that liver gets a time for hepatic recovery. And how this hepatic recovery is there? By prevention of SOD, by inhibition of malondihyde dehydrogenase, and by upregulation of caspase 3 and 9. So all these can be helpful in reducing that hepatic apoptosis as well. So that's why the hepatic recovery will be there. So if you want to combine TP, so combination therapy with TP in liver disease, so what will be there? I already discussed that if you want to combine with DPMS with TP, it uses a plasma filters which continuously remove the plasma without causing any significant changes in the albumin level as well. And if they have combined DP mass with TP, what they find that some survival was 57.4% as compared with 41% if TP was used alone. And the similar studies on combining TP with hemoperfusion, a continuous a no, Mars is not same as TP. TP is different. Therapeutic plasma exchange is there. Mars is more or less, you can say that Mars is closer to DP mass. Okay, it is not like TP. It is closer to DP mass. The principle is almost same, but the Mars has bit. Uh, it have more features of doing liver transplantation. If you are planning to do a liver transplantation, you because Mars is also known as artificial liver. Okay, so that's why it is more closer to DP mass, but it is entirely different from TP. It is not TP. Okay, and that's why major limitation in these groups of patients. What is major limitation? That if the patient is hepatitis B related acute liver failure, then the large cohort of study or more diverse etiology is there. That's why it is one of the limitation. Okay. So this is all about, I think I have covered almost all aspect of your question today. We have started with severe preeclampsia, and we have went to your the DP mass and the therapeutic plasma exchange. But definitely you have to read orthotopic liver transplantation indication for acute fulminant hepatic failure. What could be the indication? What is the organ transplant criteria? Because it is entirely a different examination. But definitely all stents has been tested. We have started our journey from preeclampsia, then severe eclampsia, then your HELP syndrome, then your amniotic fluid embolism, then patient was having AFLP, then we went to fulminant hepatic failure, then we have discussed like that. So the similar pattern will be asked in your exam. So this is all about from my side. If you have any question, I will be happy to answer. So go and read the obstetric emergencies today. And I think it's a very important topic, and you all guys will fetch good marks also if you'll have uh, if you have interest in means reading, because I have left many of the part. I have left maternal sepsis. I have left your peripartum cardiomyopathy. I have left, I think, your role of your vaccines in the pregnancy, like the if the patient will have some H1N1 problems, and then what could be the management in those groups of patients. So this is, I think, important, है ना? So basically, I think you have talked about that Mars. So it is basically used for your for treatment of your acute fatty liver as well. And then your if the patient is acute on chronic liver failure, or patient is having a severe hepatic encephalopathy, in these groups of patient, you may provide a Mars, which is your molecular absorbent recirculation and system. Basically, it's a molecular absorbent recirculation system. Okay. Basically, it's a extracorporeal, or you can say that's a extracorporeal albumin dialysis. Extracorporeal albumin dialysis, also alternative name for Mars. The principle is a bit different. Okay. So I think again, best wishes from my side for your edict too, and hope if we have a discussion related to question and answer session, then if I will be there as examiner in your viva, so I think again an interesting discussion will be there, because here while talking it's very easy to see all those slides. Okay, but it is difficult when you are facing the real examiner. It is always difficult. Many of the time candidates is knowing the answer, but they will not able to speak in front of screen. So you try to practice and practice. And I think the Forge Academy already taken a huge initiative to help you all. And we have a passing rate of more than 85% almost. If you are clear, if you are very patiently attending the classes and very closely reading, because it's not that you read all those means all those very rare things. It's important that, because in the EDIC examiner, they used to ask a very basic questions, and then they will go in some more details, just like that what we have discussed. We have started with a very basic question, and then advanced question is there. So it is not often, if you answer all is basic question, you will pass in your exam, because all those having a five stems, and all five stems has to be answered. Okay. So if you don't have any question, I will be happy to leave. Thank you. Fatima, can I leave right now?
Yes, sir.
Okay. If they have any question, please ask them to, or you can share me that question later on. Okay.
Thank you, sir, for the
Thank
session.
you.